Very good afternoon, everyone. So I'll be speaking about the mechanisms of resistance to exon 20 insertion TKIs and therapies post-resistance. I'll rush through my initial presentation because most of it is a repetition of what Dr. Omshri and Dr. Arun have highlighted. So this is the third most common class of EGFR mutations, and it's heterogeneous in size. It's insertions or duplications of 1 to 7 amino acids between the alpha C helix and the following loop of EGFR. It also happens in the HER2 gene. We know that HER2 mutations are present only in about 2% of the NSCLC cases. And the most common HER2 mutation that is seen is exon 20 insertion, but again at the same location between the alpha C helix and the following loop. Problem with exon 20 insertion is that this is a clinical unmet need because de novo resistance to clinically approved EGFR inhibitors, first, second, and third generation drugs is very common. And exon 20 insertions, unlike the classical EGFR mutations, can activate EGFR without diminishing ATP affinity versus the wild type kinase. So that negates the advantage of ATP competitive inhibitors to selectively target mutant over wild type EGFR. There is drug accessibility is very limited when there's an exon 20 insertion, as Dr. Omshri has highlighted, that there is a very rigid C helix conformation, because of which the drug binding site becomes very compact. And there is an extremely narrow therapeutic window. So it prohibits clinically approved EGFR inhibitors from reaching therapeutic doses, which can selectively target the EGFR exon 20 insertion mutants over wild type EGFR without causing significant toxicity. One exception is this particular mutation, that is A763Y764, which has a very high affinity for even the first generation EGFR TKIs. Apart from this exception, in general, EGFR TKIs are not currently being used to treat EGFR exon 20 insertion patients. So the current standard of care is cytotoxic chemotherapy. Only about 2 agents are FDA approved for the treatment of exon 20 insertion targeted therapies. And a lot of preclinical and ongoing clinical trials are there, which are investigating other experimental therapeutics. I'll just recapitulate the drugs which are being investigated right now, and some of them have already been approved. We have the exon 20 insertion TKIs that act at the ATP binding site, poziotinib, mobocertinib, and another experimental agent. And then there is a dual targeting antibody, that's amivantamab, which is also FDA approved. There is a heat shock protein 90, that is HSP90 inhibitor, that is luminespib. So these are the drugs which are being investigated at present. I'll skip about the individual drugs. It has already been highlighted by Dr. Arun. So luminespib is one thing which I would just like to talk about. It's an HSP90 inhibitor. Why this drug is important, I'll come when I talk about the drug resistance mechanisms. In general, it's very well tolerated. It just has low-grade reversible ocular toxicity. A phase 2 study that was done in advanced NSCLC patients with EGFR exon 20 insertion, there was an overall response rate of 17% and a PFS of 2.9 months. HSP inhibition is a potential therapeutic strategy. So whatever data we have so far, it highlights the challenges in addressing EGFR exon 20 insertion inhibition. There is a significant toxicity with most of the agents that we have so far because of inhibition of the wild type EGFR, lower overall response rates, probably because intrinsic and acquired drug resistance, it's a major limiting factor. The reasons for lower response rates and shorter median PFS is, one thing is that there's insufficient dosing due to toxicity. There is rapid acquisition of resistance with mechanisms very similar to classical mutant. And understanding these potential routes is very important in order to achieve any durable responses in EGFR exon 20 insertion NSCLC. So what are the mechanisms of EGFR exon 20 insertion resistance, which is precisely the point of focus of my talk. So there are mutations, on-target mutations like T790M and C797S, and there are activation of other pathways like PI3K, AKT, RAS MAP kinase pathway, and amplification of some cell cycle genes like CD6. Acquisition of on-target secondary mutations in EGFR, including T790M gatekeeper mutation and C797S mutation, also play a role in the resistance to exon 20 insertion TKIs. We know that T790M is located in the ATP binding pocket. It leads to resistance to first generation competitive EGFR TKIs by steric hindrance. That leads to an increased affinity for ATP and a reduced affinity for EGFR TKI. This resistance can be overcome by osimertinib because it selectively binds to C797S of the EGFR. If there is a mutation in the C797S, that prevents formation of key covalent bonds between osimertinib and the thiol group. And that causes resistance to osimertinib as well. So T790M, C797S, and many other on-target mutations play a role in the resistance to EGFR exon 20 insertion TKIs like poziotinib also in the preclinical models as well as in the poziotinib phase 2 trial. There was one particular mutation, C805S, that accounted for resistances in almost 1/3 of the resistant clones. It led to a 100-fold increased resistance to poziotinib. Luminespib, which I had described earlier, it's a HSP90 inhibitor that was able to reduce the viability of HER2 exon 20 insertion cells regardless of the presence of the C805S mutation. So how far this would convert into clinical benefit, we need to see, because HSP90 chaperone complex, it's known to protect cellular proteins from ubiquitin degradation. So this table gives a list of what are all the mutations, amplifications, and copy number losses which can happen at baseline as well as post-treatment that can lead to exon 20 insertion TKI resistance. There are other resistance mechanisms also, like co-occurring mutations in KRAS and ERBB4, activation of MAP kinase, MEK, AKT, and ERK pathways, which are seen in tumors and preclinical models which progressed on poziotinib. Another important thing that was seen in the poziotinib phase 2 study was MET and CDK6 amplifications. MET and CDK6 amplifications, it leads to a resistance. This resistance mechanism is there even for the approved TKIs, and they are potential druggable targets in order to overcome resistance even to EGFR exon 20 insertion TKIs. So most of the EGFR exon 20 TKIs are still in the initial stages of clinical development, and our understanding of their resistance mechanisms is very limited. Most of the resistance mechanisms overlap with the classical EGFR mutation resistance mechanisms. Another important concept is the EMT, or epithelial to mesenchymal transition, which confers resistance to the clinically approved EGFR inhibitors that plays a role even in resistance to EGFR exon 20 insertion TKIs. So this acquisition of an EMT phenotype is seen in response to geftinib both in vitro as well as in patients. Basically, it leads to a decrease in the expression of epithelial marker E-cadherin. That causes an increased expression of ZEB1, which inhibits the expression of BCL2-like protein 11, or BIM. BIM is basically a pre-apoptotic protein that's required for EGFR TKI-induced apoptosis. So downregulation of BIM will lower the level, and that makes the cell undergo EMT, which protects against EGFR TKI-induced cell death. And the ZEB1 is also linked to increased expression of fibroblast growth factor receptor 1 that's associated with resistance to EGFR inhibitors. So FGFR1 inhibition is another potential area. If that can be done, then that can restore the sensitivity to EGFR TKIs in acquired resistant cell models with an EMT phenotype. So that's how EMT indirectly has been identified as a potential mechanism of resistance to poziotinib. There is another concept of drug tolerance, emergence of minimal residual disease, a subpopulation of drug-tolerant persister cells, or DTP cells. So this is a small subpopulation of cells which remain viable even in the presence of anti-cancer treatments, despite not harboring any of the classic genetic mutations which are commonly associated with drug resistance. They undergo a drug-tolerant reversible state, which is observed in numerous cancer models in vitro and in vivo in response to drug pressure. And this is probably a general phenomenon. The drug sensitivity can be more than 100-fold less in DTP cells when compared to the bulk tumor cells. This happens because of epigenetic modifications, and this reversible DTP state could also account for the resensitization of patient tumors to TKIs after a drug holiday. Given that DTP cells have been observed in response to clinically approved EGFR inhibitors, Similar phenomenon may be seen with exon 20 insertions also. So upon treatment with exon 20 insertion TKIs, what happens is a small subpopulation of clones will enter this resistant, slow-growing state, and it facilitates escape from drug pressure. Then these DTPs will develop multiple de novo resistance mechanisms, and then they'll allow them to revert to a fast-growing stage, eventually becoming the dominant population in a relapsed tumor. Understanding the biological mechanisms driving the evolution of DTP cells will undoubtedly help in the design of more effective upfront therapeutic strategies for EGFR exon 20 insertion patients. So these are the strategies which Dr. Arun has already highlighted that have not shown much benefit. Higher doses of osimertinib, combining cetuximab and afatinib, immune checkpoint inhibitor therapy, they all have got largely disappointing results. So to summarize, resistance mechanisms to EGFR exon 20 insertion are very similar to those that are seen with classic EGFR mutation TKIs, including on-target mutations, activation of other signaling pathways, EMT, and emergence of DTP clones. Novel approaches designed to overcome resistance beyond fourth-generation TKIs, including combination therapies, antibody-drug conjugates, bispecific antibodies, and immune-directed approaches are at various stages of clinical investigation. Understanding the molecular basis of various resistance mechanisms paves way for identifying potential drugs to overcome the resistance. And one of the main challenges when multiple alterations are found is to elucidate which mechanism is driving the resistance to efficiently target that mechanism and improve the chances of therapeutic success. Thank you.